Good afternoon, everyone. My name is Dr. Jason Wong. I'm a physician from the Neurology Unit in Sarawak General Hospital. I'm very grateful to be involved in this edition's Motor Neuron Disease Beyond Borders. Our main agenda today is a case presentation sharing session. And from the Neurology Unit, we would like to take you through a patient's diagnostic odyssey of motor neuron disease through the involvement of multidisciplinary team management. To start, I would just like to spend a couple of slides on motor neuron disease. Motor neuron disease are a group of neurodegenerative disorders that affects motor neurons in the brain and spine to progressively lose its function. Motor neurons are a type of nerve cells that helps control voluntary muscles of the body. And this can be divided into upper motor neuron and lower motor neuron. This is important as dysfunction of these will manifest as clinical signs recognizable on examination. Diagnosis of motor neuron disease is made on clinical grounds by an accurate history and physical examination. There are various criteria available to help us reach a diagnosis with various level of confidence. However, there's still no specific test available to confirm the diagnosis. The cause of motor neuron disease is still not well established, but we do know that genetics play a role. And this opens up therapeutic windows for various researchers to explore. And we do know that 10% of motor neuron disease are due to mutations. And there are a history of family clustering. The mean age of onset of motor neuron disease is between the 5th to 6th decade, with a mean age of onset of 62. However, and it is possible for an individual of any age to develop motor neuron disease. The progression of motor neuron disease is variable, and it also depends on what type of motor neuron disease. There is no two individuals with motor neuron disease who ever behave the same way. So this is why we said that the progression is quite variable. However, on average, survival rate averages between 2 to 5 years from diagnosis. There are a few recognized types of motor neuron disease depending on whether an upper motor neuron is involved or a lower motor neuron is predominantly involved. However, ALS is the most common and well-publicized subtype. I'm sure the public is well aware of the Ice Bucket Challenge in 2014, which raised considerably amount of not only funds, but also awareness among the public. There is unfortunately no cure for motor neuron disease, and mainstay of treatment remains symptomatic as well as to optimize the quality of life. So what are the symptoms of ALS? Depending on the type of motor neuron disease being involved, an individual can experience various symptoms from spasticity, muscle cramps, weakness, and later on, if they progress to difficulty walking as well as doing normal daily activities. And if their weakness progresses up to the upper limbs and even to the bulbar segment, they can get difficulty in swallowing as well as changes in their speech. And in later stages, if the weakness progresses up to the breathing muscles, they can get difficulty and effortful breathing. So next, I'd just like to move on to our case sharing session. This involves a patient, Mr. AA. He is a 59-year-old gentleman. He is of Malay ethnicity. He used to work as a police assistant officer, and he retired at the age of 55. He was quite well up to that point and even up to 1 to 2 years after his retirement. He does not have any bad habits such as smoking or consuming large amounts of alcohol. Prior to this, he only had hypertension, which was relatively easily controlled with a single agent. He is well married with 5 children. His wife used to work as a nurse, and he comes from a big family of 10 siblings. Something of concerning of note from the family history is that his father had stomach malignancy. So this was something which we had to exclude when we evaluated Mr. A. So Mr. A was first referred to our clinic in the middle of 2019. However, he had already started experiencing symptoms 1 year preceding his appointment in our clinic. He described his symptom onset as having progressive bilateral lower limb weakness, and this manifested as walking shorter distances. He experienced frequent muscle cramping in his lower limbs. He had reduced stamina. And subsequently, as the weakness progresses, on the year he was referred, he developed weakness progressing up to his upper arms as well, and in particular affecting the fine motor movements of his hands. Subsequently, the weakness also progressed up, and this involved his swallowing muscles. He had difficulty swallowing, he had changes in his speech, and all this affected his nutritional status, and he suffered a significant loss of weight of more than 20 kilos. In his prime, he was a fit 70-kilo gentleman. However, when he came to see us in the clinic, he was less than 50 kilos. So these are just some pictures that I just like to show. This is the picture of Mr. A, and I just wanted to highlight that you can see that there's various muscle wasting, and the first picture, you can see that there's wasting of the tongue, there's wasting of the forearm, there's wasting of the hands. The hands appears deformed. It looks like the hands are in a claw-like position. In the thighs, there's also significant wasting involved. And if we look closely, unfortunately, I do not have a video. There's also fine quivering of the muscles known as fasciculations. So we actually admitted Mr. A to the ward and for further evaluation. And we did some further tests. However, like I mentioned before this, there's no specific test to confirm the diagnosis. Tests are mainly done for exclusionary purposes. And in Mr. A, his blood tests were all quite normal. And subsequently, we proceeded with further imaging to exclude other possible causes that could explain his weakness. And all of this came back negative, including his MRI, brain and spine. We subsequently proceeded with a nerve and muscle test. So this is an important part of our assessment, and that helps to add weight in to add supporting evidence to help us gain more confidence in diagnosing this motor neuron disease. And both of these tests were quite supportive of a possible motor neuron disease diagnosis. So after getting his history and examining him, we came to a conclusion that he had lower motor neuron as well as upper motor neuron dysfunction, and this manifested as weakness and wasting over his tongue, his forearms, as well as his lower limbs. The upper motor neuron signs was actually he had preserved reflexes. Apart from that, an important aspect of his examination was that there was no sensory involvement. We do know that the sensory nerves are a different part, and this were not affected. So we do know that motor neuron diseases that spare the sensory nerves. So this was an important point of his examination as well. So like I mentioned, his nerve and muscle tests were supportive as well, and his neuroimaging did not show any other possible explanatory diagnosis to his symptoms. So in the end, we concluded that he had motor neuron disease, and the type of his motor neuron disease was likely ALS or amyotrophic lateral sclerosis. So these are just other signs of motor neuron disease that I'd just like to show. These are videos. You can see the first picture with the lady in the hands. You can see that there is some wasting of the hand muscles around this portion here. This is otherwise also known as a split hand sign, where motor neuron disease preferentially affects what we call this part of the muscle group known as the thenar muscle groups. So this is a clue for us clinicians that help us to recognize this, whether this patient could be having motor neuron disease. And some other videos just showing that the presence of fasciculations, which are quivering or fluttering of the muscles that have been undergoing denervation. You can see that this gentleman also had wasting of the forearm muscles. And this gentleman had a very wasted tongue. So obviously he had speech changes and difficulty swallowing as well. And this last video just shows that some of our patients, they get abnormal movements, such as this, looks like piano playing fingers. And this is otherwise known as polymini myoclonus. And it's a hyperkinetic movement disorder that is closely linked with anterior horn cell diseases like motor neuron disease. So this is the care pathway for motor neuron disease, and we follow this pathway similarly in our setting. So once a patient has been diagnosed with motor neuron disease, they get referred to the multidisciplinary team clinic, and that is where we have various subspecialty teams involved as well as allied health to help manage the patient the best we can. So just a bit about multidisciplinary team approach. So both the American Academy of Neurology as well as the European Federation of Neurological Sciences recommend that multidisciplinary team care setting actually improves survival in patients with motor neuron disease. It reduces their complication as well as improves the quality of life of patients and their caregivers. So our MDT clinics in Sarawak General Hospital is held in the rehab clinic, and it occurs every month. And another part that I would like to mention is the support groups, such as MND Malaysia. So this slide just shows that there's a lot of personnel involved in the multidisciplinary care of a patient with motor neuron disease. From the core, we have the neurology team, we have the palliative care specialists, the rehabs, the allied health, such as the speech therapists, occupational therapists, and physiotherapists. And in the later stages, we might have to involve the respiratory specialists as well as palliative care specialists. And the outside circle are great supporting teams as well. However, in our setting, we do not have such vast resources available to us. Okay, and another part I'd like to mention, despite we also have to recognize actually the core management of these patients are not just the doctors, but actually the core, the most important person in managing a patient with ALS is actually the caregivers. So going back to Mr. A, so this just shows the progression disease timeline of Mr. A. So he started experiencing symptoms in 2018. At that time, he was still independent. He was able to walk. And subsequently, a year later, he developed progression of his weakness up to his upper limbs as well as his swallowing muscles. And it was at that point he was only referred to us. So subsequently, we were able to come to a diagnosis because at that point he had quite florid signs and quite concrete and florid signs of motor neuron disease. So there was not much of a problem in his diagnosis. So at that point, we started him on medication known as Riluzole, which has been proven to modestly expand prolong survival in motor neuron disease by an average of 3 months. However, over the last 2 years, we have been following him up, and we can see that over the years he has actually progressed even further, and he has developed further complications. He's becoming more and more disabled. He now needs a wheelchair. He has flat foot. He's lost a lot of his nutrition, and eventually he now needs a PEG tube to sustain his nutrition. He gets progressively fatigued. He gets increased very effortful breathing, and this is the main focus of our discussion today as well, and it will involve much. I would pass that on later to the rehab team of Dr. Chai as well as Dr. Yong from respiratory. Like I mentioned, this very much mirrors Mr. A's progression. So in 2018, he had early features of ALS. He had weakness, cramping, he had frequent falls. Subsequently, when he came to us, he already had difficulty swallowing and difficulty in eating. And over the last 2 years, unfortunately, it seems that he has actually come to the later stages of ALS. So despite that, there are still many, despite not having an effective cure or a disease retardation medication, there are still medications available to address the common symptoms of ALS, such as spasticity, pain, excessive oral secretions, fatigue even, and also not to forget the psychological aspect of motor neuron disease, which is to address things like depression, anxiety, which which I feel in this patient we have failed to do so. So that is something which we will have to re-explore. So again, going back to him, so for this patient, our management mainly involve these various teams. Like we mentioned, we work together with the rehab, the physiotherapist, as well as the occupational therapist to optimize his functional status. However, currently, as his diseases progresses, he needs a lot of other support, such as PAC tube, as well as ventilatory support as well. So like I mentioned, the most important member of this team is the caregiver. So the next part, I'll just like to just a bit of about living with motor neuron disease. Receiving a diagnosis of motor neuron disease will be life-altering. So coping with LS is a very individual process. Everyone responds to it very differently. There's no right or wrong way to feel when you learn of your diagnosis. It may trigger a wide range of emotions such as anger, sadness, dismay, or even fear. However, an important aspect is, you may have LS, but LS might not have you. So it does not mean you cannot have a life. It means you need to go about your life differently and you need to make adjustments. There are various support groups available, MND Malaysia, as well as Yayasan LS in Indonesia. So MND Malaysia is an NGO group that provides a platform as well as a support network for patients with LS as well as carers with LS. And these two groups, they came up with this very resourceful guide on frequently asked questions on LS. I do recommend that everyone, if they have time and you have further questions, and that this resource is available on the website. Besides that, the LS Association also publishes this very resourceful guide again. There's a total of 11 chapters, and I do recommend you having to go look at this. It is available on the website as well. For caregivers, it is a very stressful time if you have someone with LS. So seeing someone close to you affected by the disease, like I mentioned, you are the most important person in a patient with LS. So it is also very important for you to take care of your own health, practice self-care. You have to value yourself, manage your stress. If you're unable to do so, do ask for help. Look for your own support network as well. There's even this caregiver bill of rights that is available online. So I do please have a look at it if you have time. And there's also this guide being published by the LS Association as well. Coming to the end of the talk, in our population, this is a frequent topic that regularly comes up in clinic, is how to maintain a good nutrition. So the LS Association also provides guides regarding the importance of maintaining a well-balanced diet, tips on safe swallowing, as well as guidance on feeding tubes. If you have time, again, I do recommend going through this resource that's available on the website as well. And lastly, LS and COVID. Well, COVID does not spare patients with LS. In fact, patients with LS, you are more vulnerable to COVID. So, however, the standard still applies. Do get vaccinated. It's not contraindicated. You still have to practice social distancing. In fact, patients with LS who get COVID are 3 times more likely to pass away compared to those who don't have LS. And this can be very serious. So we do have to keep this in mind, and if possible, like I mentioned, practice social distancing, limit carers, and practice hand hygiene always. So with that, I've come to the end of my talk.
Hi, good afternoon, everyone. I'm Chai, rehab medicine physician and lecturer in Sarawak General Hospital and University Malaysia Sarawak Unimas. Thanks MND Beyond Border for the invitation for the MND cash sharing on Sarawak or the land of Hornbill. So I'm going to present the rehab part for our case. For my part, I also asked to introduce some exotic animals of Sarawak. So these are exotic hornbill and orang-utan in Sarawak. I would like to thank Dr. Lim from MND Beyond Border and Dr. Leong, Head of Department of Sarawak General Hospital Rehab Medicine Department for coordinating this case sharing. I'd like to thank the previous lecturers and professors in UM who are expert in MND for the knowledge and skills in MND management and rehab. I would like to thank Sarawak MND multidisciplinary team for the assistance in this case sharing. So this is my hometown, Kuching, Sarawak, where the Sarawak General Hospital and Unimas is located. And I'm currently working in Sarawak General Hospital and University Malaysia Sarawak. And Kuching is at the southern part of Sarawak. So from the jungle of Borneo in our Sarawak National Park, you can find exotic animals like hornbill and orang-utan. And from jungle of Borneo to modern Kuching city, where you can see a lot of beautiful buildings. And this is where the Sarawak General Hospital is located at. And this is where our case today is following up for his motor neuron disease treatment and rehab. So this is University Malaysia Sarawak, the public university of Sarawak, where I'm currently working in the university for medical academic duty like teaching and research. So our case is Mr. A, 59 years old gentleman. He was diagnosed ALS since 2019, which was described by our neurology team just now. So it's currently at stage 5 of ALS. So these are the 6 stages of ALS. So when he was first diagnosed, he was at stage 3, and currently is at stage 5 of the ALS. So for stage 5 of ALS means he is non-ambulatory, means he cannot walk, but it's not bedbound, and the PADL means the personal activity of daily living is maximally dependent. For 1 to 3, ambulatory means he still can walk. Then there's a mild, moderate, and severe weakness. For 4, 5, 6 means the pulse cannot walk. Non-ambulatory means cannot walk. Non-ambulatory, and the PADL is moderate dependent, maximal dependent, and total dependent. So it's currently at stage 5. Non-ambulatory, cannot walk, not bedbound, but the personal activity of daily living, like wearing clothes, everything is maximal dependent. Has required assistance from the carer. So rehab role or goal in this MND case is to optimize the function of the pulse and maximize the independence, minimize the disability, improve quality of life, and address possible impairments at various stages of disease, and to reduce complications like lung infection or limb contractures. So for this case, he has actually many impairments or problems, but due to time constraint, we are requested by the organizing team to focus on one main issue. So the main issue that we're going to focus today is a problem with the respiratory or breathing system. And his main concern is the impact cough. The other respiratory part will be presented by the respiratory team. So I will focus on the impact cough. So in this case, the pulse has impact cough. His main concern is difficulty to cough. The cough is actually important to maintain a clear airway to prevent lung infection. So in our breathing system, there's a vocal cord. Vocal cord actually functions to protect the airway and the lung from the food particles of foreign bodies, the vocal cord here or the throat. So if the vocal cord or the throat is weak in ALS, it fails to protect the lung from foreign bodies like food particles. So the vocal cord is not just producing sound or voice, it also helps in the protection of the airway and lung. So cough process actually involves 3 phases, like inhalation phase, compressive phase, and expulsive phase. For a normal person, during the inhalation phase, then after irritant, then we'll inhale the air into the lung, and then the vocal cord or the throat will close, so that the pressure will build up in the lung, with the expiratory muscle is contracting, and the continuous expiratory muscle is contracting. Then with the opening of the throat, then the air will come out, and this is presented as a cough. So for motor neuron disease or ALS, the MND actually affect all the 3 phases: inhalation, compressive, and expulsive phase. So for inhalation, they will have limited inhalation due to the breathing muscle weakness. And then the vocal cord weakness and the dysfunction, poor posture will affect them to have the efficient compressive phase. Then the weakness of the expiratory muscle will cause them to have the reduced exhalation flow rate due to the expiratory or the exhalation muscle weakness. So MND actually affect the inhalation, compressive, and the expulsive. So for the cough, if we improve the inhalation, it will also improve improve the more air coming in for inhalation. It will actually result in better expulsive or better exhalation. So these are all related. Better inhalation will result in better expulsive. So peak cough flow is a value, or peak cough flow is used to determine the light effectiveness of the cough. So for ALS or pulse, we use this modified peak flow meter. There's a face mask and a peak flow meter. The face mask is because the pulse, sometimes they have this weak oral seal or the weak oral muscle, they're causing the air leak from the face air leakage. So we use the face mask to have properly seal to prevent any air leak, to have more accurate value. So there are two important values here. Peak cough flow, if less than 270, means pulse have inadequate airway clearance, and this require intervention. And the other value is 160 liters per minute. This means the critical level of airway clearance, and the pulse will require trial of cough assist, or two value, 270 and 160. 270 inadequate airway clearance, just intervention, and 160 is critical level and require trial of cough assist. So for the peak cough flow technique, so we have the modified here with a face mask and a peak flow meter. Then we will set at the 0 here and hold the peak flow meter so that the fingers are clear of the scale and the slot, and place the mask securely over the patient's mouth. Instruct the pulse to inhale deeply first and then cough as strongly as possible. Then we take the best of 3. We repeat 3 times and take the highest score, best of 3. So there are several methods to improve the cough effectiveness, like breath-taking, manually assisted coughing, and cough assist machine. So in our case, we are focused on this breath-taking, which our pulse is using. So for our case, his baseline peak cough flow is 210 liters per minute. So it's less than 270 liters per minute, which means he requires an intervention. And he also has a poor cough effort. So after he started on this assisted breath-taking with the lung volume recruitment bed, his peak cough flow actually increased around 50% to 320 liters per minute. And it also improved in the self-reported cough. So what is breath-taking to improve the cough? So what is breath-taking? So breath-taking is just a process where you stack one small breath, like this, this is a stone stacking at the beach. You can stack, as an analogy, you stack one small breath on top of another small breath until your lungs are maximally filled. So breath-taking also referred as a lung volume recruitment. So breath-taking is useful when the breathing muscles are weak and taking a deep breath is difficult. So by stacking a successive small breath, pulse can actually take in a big, deep breath here. So if more air can be taken into the lung, more air will be expelled. So the cough effort will be increased. The cough efficiency will be improved and able to clear the lung secretion. So more air in and more air can come out, and the cough efficiency will improve. So this idea of breath-taking, stacking the small breath to fill the lung to maximal capacity. So the benefits of breath-taking include, the first one, very obvious one, is for this case is an increased cough effectiveness to clear the lung secretion. Besides this, it also increases the lung volume, the lung chest suppleness, improves the speaking volume, and in fact, it also reverses the deflected lung area, reverse the microatelectasis. This is a medical term. The deflected lungs areas usually occurs when the areas of the lungs are not routinely filled with the air. So we fill the lung with the air, so it will reverse the deflected lung area, and it's good for the pulse. So breath-taking to improve cough, there are two methods. One is unassisted breath-taking, which are known as a gulping or throat breathing. So this involves a series of gulps like this. This diagram is gulping the air with the oral oral muscle, lips muscle, oral muscle, lips, tongue, and throat muscle to push the air into the lungs. But the unassisted breathtaking is limited in a pulse with vocal cord weakness, like in this case, because the vocal cord, in order to have efficient unassisted breathtaking, pulse require a functioning vocal cord so that it can hold the breath during the breathtaking. So the other method is the assisted breathtaking with back bowel mask. So these are used for the pulse with the vocal cord weakness, as the one-way valve helps the pulse to hold the breath. So the one-way valve will substitute the vocal cord to help the pulse to hold the breath. So in this case, we do not use the unassisted breathtaking due to the vocal cord weakness. Then instead we use the back bowel mask with the one-way valve to help the pulse to hold the breath. So breathtaking with the lung volume recruitment bag, the setup of the bag consists of 3 parts. First is the resuscitator bag or ampoule bag, one-way valve, and the face mask. So the one-way valve is important so that the air can be inhaled in one way. So by inhaling in one way, it will help the pulse with vocal cord weakness to hold the breath. Means the air can be inhaled but cannot be exhaled. So when we want to use the lung volume recruitment bag for the breathtaking, make sure there's a one-way valve, because some usual resuscitator bag doesn't have this one-way valve. So in order to have the pulse to have efficient holding of breath, one-way valve is required. So how to do the assisted breathtaking with the lung volume recruitment bag to improve the cough in this case? First, the pulse need to sit in the upright position, then hold the face mask firmly to prevent any air leak. Then after that, when we squeeze the bag, the carer, caregiver, or cows squeeze the bag, then ask the pulse to breathe in and hold. So every time squeeze the bag, breathe in and then hold, breathe in and hold, breathe in, hold, breathe in, hold, breathe in, hold, around 3 to 5 repetitions until pulse can feel the stretch across the chest, means already reached the maximum capacity. Then we remove the ampoule bag, and ask the pulse to breathe out all the accumulated air as a cough, effective cough. So this complete one cycle of breathtaking. So basically, breathe in, hold, then until maximum capacity, ask the pulse to cough out any secretion. So these are one cycle of breathtaking. So the number of breathtaking, the cycles, and the frequency depends on the difficulty of the lung secretion clearance. Usually it's 3 to 5 cycles, 2 to 3 times per day. But in this case, it's 4 cycles and 2 times a day. So if the pulse still has a weak cough, the breathtaking, which target the inhalation phase, can be accompanied by a manual assisted cough during the exhalation phase. So this is a manually assisted cough targeting the exhalation phase. So this abdominal, there are 2 methods. This is abdominal thrust and rib compression. So abdominal thrust means the caregiver, the cows will perform the abdominal thrust in coordination with the cough. So improve the expiratory flow. Then if in some cases where the pulse had the recent stomach surgery or some ulcer, bleeding ulcer, it's not suitable for abdominal thrust, then the alternative is rib compression, where the carer place the hand over the lower rib cage and pressure will be applied as the pulse cough, and then will improve the expiratory flow. Okay, so the manually assisted cough is targeting the expiratory flow in addition to the breathtaking. Breathtaking is targeting the inhalation flow. So in this case, the pulse actually can generate efficient cough just by the breathtaking alone. So no additional manual assisted cough is done during the exhalation phase. So this is the cough assist machine. Cough assist machine can simulate a cough by utilize a positive inhalation pressure, which is delivered gradually, then followed by a sudden rapid shift in negative exhalation pressure, then simulating a cough. Then the pulse can cough out the secretion. So this usually is indicated if the pulse failed the breathtaking or trial of cough assist if the peak cough flow is less than the critical level of 160 liters per minute. For in this case, our pulse, the peak cough flow is higher than 160 liters per minute, and he's satisfied with the breathtaking. So he doesn't proceed to the cough assist machine. And the other thing is the cough assist machine is expensive. This is a high technology machine. It's expensive compared to breathtaking. But these are indicated if failed breathtaking or is peak of flow is less than the critical level. So in our case, the pulse is actually satisfied with the breath taking with the lung volume recruitment bed method. So his cough effort actually improved, and he has no episode of chest infection, which is a good thing. Until one day during the MCO. MCO in Malaysia is the movement control order for the COVID, during the COVID time, the movement control order period. During the MCO, everyone had to stay at home. So our pulse is bored and staying at home. Then he has this craving, strong craving for the favorite chocolate drink. But he has this PET tube. PET tube means the percutaneous endoscopic gastrostomy tube due to difficulty of swallowing. So he was inserted this PET tube. So was ordered new by mouth, means cannot eat anything, by the therapist, speech therapist who assess the swallowing. So he was instructed not to eat anything, but he has strong craving for the chocolate drink. So he took a sip of the chocolate drink, but he has ordered new by mouth for quite some times. So he just realized that he had adequate taste. Then he rushed and took a gulp, around 1/4 of the cup of 600 ml, around 60 ml. Then subsequently he choked and panicked. Then he developed shortness of breath and fever and sent to hospital and treated as the aspiration pneumonia or lung infection. So for this case, this scenario, we have to reflect, we have to think how to satisfy the pulse craving to improve his mood and quality of life, and at the same time prevent the lung infection or the aspiration pneumonia due to his difficulty in swallowing, the dysphagia at the same time. Because he is instructed not to eat, but he still want to test the chocolate drink. So any method to have the best of the both worlds means he can test the chocolate drink, but at the same time prevent aspiration pneumonia. So just now we mentioned that our pulse has the impact test, means reduce of the test. So perceived reduction of test in ALS patient is actually reported in studies. So in particular in the non-oral feeding group, means the enteral feeding group, means those on tube feeding or PET tube feeding. But the exact cause of the impact test is still unclear. So impact test can be distressing, can affect the psychological aspect and quality of life. So for this case, instead of alternative for the new by mouth for the difficulty of swallowing, we can consider test for pressure. Test for pressure basically means tapping of the pulse favorite test to the tongue. So without actually swallowing any food or fluid to prevent the aspiration pneumonia or lung infection. So there's a paper also mentioned that the regular stimulation of the test bud can possibly avoid the worsening of the impact test over time and has a test rehab effect to improve the impact test. But this will require a further studies. So instead of like totally cannot eat, then we can use this test for pressure for the pulse to test. So test for pressure basically means there's a few steps. First, we have to ensure the mouth is sufficiently clean. Then we use a non-flaring gauze, means there's no flare. The flare we can cause accidentally swallowed and cause lung infection. So non-flaring gauze means there's no flares here. Then we wrap around the spatula. Then we dip and dab. We dip into the favorite drink like chocolate and then dab to the tongue. But the drink had to be appropriate concentration to the extent that the patient or the pulse can taste. So the favorite flavor can be chocolate, can be coffee or orange. Okay, so they repeat as often as required or appropriate. Make sure they have to maintain the oral care or oral hygiene. So these are tests for patient. Dip to the drink or the flavor and then dab to the tongue so that the pulse can test it without actually swallowing to prevent aspiration pneumonia or the lung infection. So in this case, our pulse is actually satisfied with the test for pressure, but because he's happy that he can test his favorite test for chocolate drink in a safe manner. So the chocolate drink actually require current higher concentration compared to previous concentration because he has an impact test. So he requires a higher concentration of the chocolate to have the similar test as previously. Then subsequently, he has an improved mood and quality of life. So for the case reflection and main learning points for this case, there are mainly two main learning points. First is for the impact cough. Impact cough can be distressing and can be possibly lead to life-threatening lung infection. So in this case, breath taking can be used as a low-cost initial method to improve the cough in ALS. just by doing the simple breath taking with the ampoule bag. So it can improve cough, like in this case, we can prevent pneumonia or infection. But the other learning point is the impact test can be distressing, can affect the psychological status and quality of life. So there's an alternative to new by mouth for those on difficulty of swallowing. We can consider test for pressure. Means the pulse still can test their favorite test in a safe manner to prevent aspiration pneumonia or lung infection by tapping the tongue with their favorite favor. So there's a paper also mentioned there's the regular test stimulation with the favor in a safe manner can possibly have a rehab effect to the impact test. But these are required further studies. Means we regular test stimulation for those non-oral feeding group, it might actually improve their test. So these are my references. Okay, so lastly, thank you. I have finished my presentation. Thank you very much.
Good afternoon. Thank you for listening at this around 3 p.m. for the stop. I'm Yong from Sarawak General Hospital. I'll be sharing about some of the respiratory management in an MND patient. Yeah. So this is the outline of my presentation, and we go straight to the introduction. ALS is a progressive neurodegenerative disease that affects all the respiratory muscle. So we know pneumonia and respiratory failure are the leading causes of death and typically happen around 3 to 5 years of the diagnosis. And lastly, sleep disorder breathing is common and not commonly addressed sometimes. So we know that MND affects all respiratory muscles, and if you have an inspiratory muscle weakness, it can lead you to have shortness of breath and then reduce on your lung volume and causing the restrictive lung disease. If you have expiratory muscle weakness, you have a poor reduced speech volume, and then you have poor cough, as what Dr. Chai had mentioned. And then if you have a weak muscle of the mastication, or we call it bulbar muscle weakness, you have difficulty in swallowing and articulation, and this will lead to aspiration and pneumonia, and all this can eventually lead to respiratory failure. So symptoms, NICE actually give a very good division of the symptoms. So basically we divide the general symptom. The patient may present with fatigue, poor concentration, memory, or memory, poor appetite, confusion, and hallucination, or sometimes lung-related symptoms like the shortness of breath. When he lies down, you feel breathlessness, recurrent chest infection, or coughing when eating. And sleep-related symptoms like sometimes being overlooked, like disturbed sleep, non-refreshing sleep, sleepiness during the day, morning headache, or nightmares. And also some non-respiratory muscle weakness symptoms, like repeated unjustified fall, a swallowing problem, voice changes, and limb weakness. So the assessment, usually the main bulk is a lung function test to assess the respiratory muscle strength. So what you do is you blow into a spirometer, which you measure the strength of your breath and you breath out. So the measurement that we call is the vital capacity and also the static mouth pressure. So the numbers that we call it when there is weakness and when your vital capacity is less than 50% predicted or 80% predicted, or we take a MIP level, and that is the pressure of the mouth is less than 40 centimeter water. As I mentioned just now, there MND patient can present with sleep disorder breathing. Pardon my jargon, means that their patient can have sleep apnea problem. We call it obstructive sleep apnea due to the narrowing of the upper airway, and then can have something called hypoventilation. We call it under breathing because due to reduction of the lung volumes or due to reduced response to our breathing central. And then also sometimes patients have periodic breathing due to other underlying heart problem, and also we call it the pseudocentral events due to a diaphragm weakness. So there are a lot of methods to diagnose sleep disorder breathing, but it is not necessary to be performed on this group of patients, especially when you are actually plan to start treatment for them due to respiratory muscle weakness. So there are some diagnosis that is easily available, like nocturnal oximetry, or some center can have the respiratory polygraphy like my center, and also we also have the polysomnography, the more advanced sleep tests. But those advanced sleep tests are mainly for those who have other sleep issue beyond sleep disorder breathing. Hardly we need to do a test for this group of patients. We go to this non-invasive ventilation. So patient or carer will ask why we need to give the patient some machine and some mask to put on the face to sleep. So we need to justify that. And then there are strong evidence since 2006 that show that this group of patients, when given this NIV treatment, they have improved in their survival and quality of life. And this is from 2006 study, and also another study back in 2015. Recently, it showed benefit in both who have severe bulbar involvement as well. So when to start NIV, the doctor will have some assessment of the respiratory muscle strength, and then some whether the patient had under breathing or not. This will give you some numbers, and then the doctors will able to interpret based on the number and the recommendation from the guideline to decide on the NIV. This is just a suggestion and recommended guideline, and eventually it goes back to the patient whether they are symptomatic or not, and then whether they are ready to start the treatment or not. Hence, before we start the NIV, the NICE actually have a good recommendation to tell us that we need to discuss with the patient about this treatment, just like the treatment by the neurologist, that you have to start it at some point of time, whichever point of time, then it depends on the provider and also the carer and also the patient when they are ready. So we have to do it sensitively at the appropriate time. You can usually depends on the provider also when they want to start at as soon as you diagnose the NMD, or when you monitor the lung function, it gets worse, or when during the onset you monitor lung function. So counseling, usually we'll counsel the family why we want, or the patient and the family, why we want to start the treatment, because it helps in their symptoms and can prolong their life. And I always tell my patient that they can stop anytime. It's always a trial on it. So if they are comfortable with it, we will continue with it. If they're not comfortable with it, after we troubleshoot many times, then they still cannot accept the treatment, we will stop. And we will make sure that patient and the carer get the proper help and advice available they needed. So when we forward them the trial of the NIV, I will start my patient, the patient will come to my clinics, and then we try and put her on the mask and then put him on the machine, turn it on, let them have a feel of the air blowing in their face first, and then let them acclimatize with the machine. After that, I will sit him down, lie him down on the bed, and then on the position that he or herself more familiar with, more comfortable. Because NMB patient, they can't sit still for too long. Usually they tend to lie down on certain position or sit in certain position they're comfortable with. So when we want to put an NIV on the patient, on the mask on the patient, we need to put it at that kind of position that patient is comfortable with, and to make sure it's adequately helping the patient. Then slowly the patient increasing the duration of usage. Of course, when we start the treatment of the NIV, we need to review the patient soon, early, so to troubleshoot any problem. So interface is important in terms of to ensure success of the NIV treatment. There are a wide range of interfaces in the market, and it depends on the patient preference, but the commonly used are all the oral nasal mask, the nasal mask, or the nasal pillow. So usually when you put the mask interface on the patient, you should not cover the eyes or the lips. And then you should be fitted in the situation at the patient use, like just I mentioned. So patient lie down on the left side most of the time, so you have to put it in such a position that the mask didn't slip up. So NIV is not without complication, and commonly is associated with the interface as well. So when you, and if let's say I use the nasal mask, is commonly associated with mouth leak, and then patient will complain dry mouth when they come back to see me. So I know they have quite a leak, and then the troubleshoot is usually I try to give them on the chin strap to reduce the leak. Because if you have significant leak, right, your ventilation will be reduced, and then it can also disrupt the patient's sleep. And pressure sore, especially if the patient is actually using it like more than 12 hours, the risk of getting pressure sore is there. And so the solution is usually we alternate with different interfaces. So sometimes the setting related complication also can arise, and it causes all sorts of asynchronous. It means that when the machine and the patient is not being synced in terms of delivering the treatment. So that a clinician actually sometimes can look into the machine and actually interpret the changes from the graph there. Yeah. So then of course we have to consider other causes that can contribute to the NIV failure, that you have the bronchial congestion causing the impaired cough, you have all the excessive salivation, and because the patient have undernutrition, then the face is getting smaller and swelling problem, leading to mouth leak as well. Yeah, so I come to Mr. A. I think Dr. Chai and Dr. Jason already explained quite a lot of his demographic. So I just briefly through on his presentation to respiratory clinic. So he came to respiratory clinic in August 2019 and presenting with to us with worsening bilateral lower limb weakness, dysphagia, and optopnia. MMRC for me is his performance status in terms of breathlessness, and he needs even he walks he change his clothes also he's become breathless, and he have some bubble speech, and then the chest expansion is reduced. We did some baseline investigation. We took the arterial blood gas, means the blood test that actually take from the artery to detect the oxygen and carbon dioxide level, that it show elevation of the carbon dioxide in his body, that actually this is suggests of something we call hypoventilation, or we call underbreathing in the layman term. The spirometry that we performed for him during the presentation show moderate restrictive abnormalities, and the respiratory muscle actually is weak because it's less than 40, -28, and the peak of flow is about 170 liters per minute. So he was started on NIV since November 2019 using also oral nasal mask. He complained of dry throat during the follow-up, and during our download of the data from the devices, is noted significant mask leak, and mainly at that point of time due to the nasogastric tube. So subsequently, he had a gastrostomy done in August 2020, and the mask leak actually improved. So this is a timeline of his NIV therapy. Just take you through is like throughout these almost 2 years, his usage actually increasing as his disease progress, and also this trigger thing is something how you actually trigger the machine to deliver the breath for you. As the time goes by and his muscle is getting weaker, you know that I can see that the patient actually needs more and more support from the machine, and things actually not helping when he got admitted end of last year for aspiration pneumonia. Yeah. So, and as a clinician, because the machine actually have provide a lot of data and information, most of the time when the patient come back to me with the machine and then I download the data, I can interpret it and see what is going on and know when to adjust the setting. So, and for this gentleman, he is doing okay, but he is almost actually I would say that 80% or 90% dependent of the machine already, because during the data download, most of about 80% of the time is the machine doing the job, the breathing when he's using it. Yeah, but fortunately, he doesn't develop any large leak problem with the therapy, and there's not much of sleep apnea problem with him. Yeah. So with that, thank you.
Thank you for the opportunity to share here today. And today I'll be sharing on perspective of palliative involvement with an emphasis on person-centered care approach in MND. And in this case, it would be Mr. A-centered approach. This talk will give you an insight from a healthcare perspective, the work that we do, the common scenarios and challenges in our clinic, and changes we wish to bring to provide better care. So before I begin, here's a little food for thought. If you had only a few years to live, would you want to know that you are dying? Would you want to make your own medical decisions? And if you can't make decisions for yourself, would you appoint someone as your surrogate decision maker? Who would that be? And in this case, who should make medical decisions for Mr. A? As I begin, let me introduce you to what palliative care is. Palliative care is an approach that improves quality of life of not just patients, but also families who are facing a life-limiting illness. It prevents and relieves suffering through identification and appropriate assessment and treatment of pain and other problems, not limited to physical, but also psychosocial and spiritual. Here, I'll highlight the involvement of palliative care in patients with life-limiting illness. Why this is important is because I think many people, when they hear palliative care, they are afraid and they will think that that's the end of life. It's like they are dying now. So let's observe the figure above on the older landscape model of palliative care, or also termed as brink of death care. As the name states, traditionally, palliative was often involved with patients in the later stages of disease, particularly during the dying phase, as highlighted in turquoise. In this model, by the time palliative team is on board and patient is dying, we are able to manage end-of-life symptoms, but the experience would probably can improve better if we know what the patient's values, hopes, and preferences are. As opposed to the newer landscape at the bottom, you can see that there is a shift in involvement of palliative care, and it's not just end-of-life care. Palliative care is introduced to patients earlier, and it can be as early as at diagnosis of life-limiting illness. Active involvement may be minimal at the beginning, but as the disease progresses and symptom burden increases, palliative involvement would increase with time to help improve their quality of life through managing of symptoms, discussing goals of care, and what is important to them when disease-modifying treatment are seen to be futile or ineffective. Certainly, palliative care also plays an important role towards the end of life and dying phase, and can continue on with bereavement support. Well, I guess MND, as we all know, is a life-limiting illness, and early introduction of palliative care at diagnosis would certainly benefit patients and be able to provide more support for carers. It also allows us to know what are our patients' goals and what is important to them. Early involvement increases the ability for patients to express their concerns and goals of care before their illness becomes too advanced. And MND patients' care needs may vary through the disease trajectory, and the involvement of the team, of the palliative team, may be episodic, occurring at times of change, crisis, or decision-making. For example, palliative care may be more involved at diagnosis, when the feeding tube is needed, when respiratory function is declining and NIV is discussed, or when there are cognitive changes, and certainly at the end of life to help them navigate through decision makings. Well, in Mr. A's case, while he was diagnosed with MND in August 2019, we started seeing him very soon in the following month during the first multidisciplinary team clinic. Here's a brief background of Mr. A, who was previously working as a police bantuan at Petronas. He is married with 5 children, currently living with his 4th son. His wife is his main carer, who has been most supportive of Mr. A's decision making. She was very hands-on with his care and excellent support as his disease progresses. She accompanied him for all his follow-ups and is coping fairly well. Well, due to work commitment, his children were not able to be there for follow-ups. No one likes being a bearer of bad news, and that includes us as healthcare workers. But in this case, during our first encounter with Mr. A, we used spikes as a communication framework. And despite suffering from dysarthria, we were still able to have a meaningful and empathetic conversation with Mr. A about his illness and what is most important to him. Our setup was in an outpatient MND MDT meeting where we have the neuro, rehab, and palliative team together. A private room was available to minimize distraction and interruption, maintain privacy, and to provide a safe place for Mr. A to ventilate and express. He was accompanied by his wife, who was there as a carer and to provide support. And after introducing myself and the work that my team does, I explored Mr. A's perception in regards to his disease. And to my delight, he was quite comfortable and eager to discuss about his disease. He was able to reiterate his diagnosis, understanding that it is an incurable disease with good understanding on the role of riluzole. On invitation to discuss further, Mr. A was very keen to know more in depth on possible progressions and complications that may entail. Well, this really goes to show that Mr. A is someone who wants to be in control, even though the outlook of the disease may be poor. He wants to know and plans his life. We managed to discuss possible progression and complications in bite-sized information and ways to help manage his symptoms. In view of a few early signs of difficulty in swallowing, difficulty in talking, and reduced effort tolerance, he was introduced to communicative tools, feeding tubes, and NIV briefly. His emotions were appropriately sad, I would say, and it was addressed, and his biggest worry and concern was leaving his family behind. What was important for Mr. A was managing his symptoms well. So he knows exactly what he wants to, and he was actually really on board with the recommendations which we provided. And he wants to spend quality time with his family. Well, as his disease progressed, it was easy for him to be on board with the suggested treatment options, which was prepped along the way, and he was keen for PEG tube and NIV. His symptoms were very much improved with the recommended management, and his wife was also seen to be calm and on board with his medical decisions. The MDT team supported him through prescribing of appropriate equipment, symptom management, and NIV titration. While Mr. A may be someone who is receptive to suggested management option, not every patient may share the same goals and values as Mr. A does. Some patients, they might consider PEG tube as something which is not acceptable to them. And some patients, they say that NIV is not something that they can tolerate. So it is very much about negotiating and also to explore what are their concerns regarding this management and what is important to them and why are they finding it difficult accepting this management. So it is important to know what is most important to them, and with that, only with that we can make better decisions. Palliative care emphasizes on person-centered approach as opposed to the commonly practiced disease-centered approach. Hippocrates said, "It is more important to know what sort of person has a disease than to know what disease a person has." A person-centered care is providing care that is respectful of and responsive to individual preferences, needs, and values, and ensuring that patients' values guide all clinical decisions. It is a care provided beyond their disease, and it is about respecting that they have their own views on what's best for them, and they have their own values and priorities in life. Person-centered care approach demands a cultural shift from our healthcare workers' perspective, from our routine practice of disease-focused care. It is essential to get to know patients as a person and actively involve them in care-related decisions. Shared decision-making is a conversation that happens between a patient and a clinician to reach a healthcare choice together. It is not paternalistic, where the doctor knows best model, where a physician believes that they know what is best for patient and the physician makes critical choices and tell the patients what he or she believes the patient needs to know. You are losing weight. You'll need a PEG tube. I'll refer you to a surgical team to have the PEG tube in. And in our local setting where most patients are not very vocal and are very compliant patients, they would most probably just nod without much understanding, and the next moment you know they are struggling with a PEG tube on. While shared decision-making is not paternalistic, neither is it an informational relationship where physician shares information but then leaves the individual to supply a decision for themselves given all the facts and figures. Shared decision-making is when the physician shares information but at the same time offers guidance and support to help patients come to a decision they are happy with. It is important that after providing sufficient and accurate information, we assess patients' understanding and allow patient and family to ask questions. Only when understanding has been achieved, we can then discuss care options, assist patients to make decisions, and most importantly, respect their decisions. And in order to assist patients to make decisions, physicians may ask patients, "What do I need to know about you to support you best?" Or other ways of reframing them to help us know what is important to patients. We can ask, "Do you feel you are in control? Have you lost your place in life? Is there anything you look forward to? What are you proud of? What do you worry?" The ultimate aim is to understand patients better so that we can negotiate the best possible care according to patients and caregivers' value. Discussion on end-of-life care is carried out to actually help patients and caregivers prepare for the eventuality. Patients with MND have particularly complex care and support needs in final stages of life, but evidence from many studies is that death from MND can be peaceful when there is a good palliation. The common discussion topics revolving around end-of-life care includes preferences on place of care and death, provision of anticipatory medications in case they deteriorate, and also advanced care planning. Well, if there's anything I learned from Mr. A, it would be the impact of having a multidisciplinary team involved in the care of a patient, just to simplify follow-ups for patients and caregivers, and the coordinated care between various teams to manage patient symptoms. Certainly, I also appreciate the impact of patient-centered approach, where we learn to treat our patients as a person rather than a disease. I guess the biggest barrier to person-centered approach is probably the culture. And I really hope that this will change in time. I would like to end with a quote, one of my favorite quotes from Patch Adams. You treat a disease, you win, you lose. You treat a person, I guarantee you, you win no matter what the outcome is. With that, I end my talk. Thank you very much.